I've had a chance to be involved for 20 years in the city of Chicago in homeless and housing services. And I come from the experience of the housing world, not so much the health world, even though we work very closely with it. So we especially have focused in our work with the highly vulnerable, those with a lot of illnesses who've experienced homelessness, and also those with disabilities. About 2 years ago, by the way, I gained my own disability. I lost about half my vision because of optic neuropathy. So I will not be able to recognize hands in the audience. That's what I'm going to ask my colleagues to help with. And I also cannot see your faces, unfortunately. So if I'm boring you, I will not know that. But hopefully I will not. So we're going to be talking about the health home, especially when it comes to supportive housing, as we're trying to do it in the city of Chicago. So basically, I'm going to very briefly go over the context of the Affordable Care Act, tell you then more about our Chicago pilot project for the health home and supportive housing, tell you about our own health home that we're putting together called Together for Health, and then future opportunities. Carlos, he is a living example of what we're trying to do here. Carlos, that's not his real name, but I can tell you he's a very real person. He had been homeless for over 10 years in the city, living with HIV/AIDS for 15, but also dealing with mental illness, with substance use, history, with hypertension, heart problems, liver disease. And look at the star there. He actually, after we housed him, this is Medicaid data. We got this straight from the Medicaid state office. Before we housed him, he was spending almost $250,000. And then it kept going down after 9 months of housing, and look at what he was spending after 20 months. Now, this is without the health home yet, because our health home is being put together. So I think you all know the cost benefits of supportive housing. This is the kind of data Medicaid loves to see for high users of Medicaid. As you may have heard, the mantra of the Affordable Care Act has got 3 parts to it. One, of course, is increase access to care through Medicaid and other health insurance. But the last 2 are just as important. The new system of healthcare in the United States is going to go from volume-based to outcome-based. So if you don't have good health outcomes, you're not going to get paid. And then, of course, you have to decrease costs. And I think this is where supportive housing can play a key role for our population. What we're saying goodbye to is the fee-for-service. Eventually, that's going to go away. I know in our state it's going to go away, and probably all over the country. Healthcare organizations or supportive housing organizations working as silos and a volume-based healthcare delivery. We're going to be much more focused on decreased costs, coordinated care, and health outcomes. And again, this is where we can play a big role. I'm going to very briefly go through with you the results of the Chicago Housing and Health Partnership, which happened almost now 8 years ago, started 10 years ago. And it was basically followed the example of the New York study back in 2000. And the New York study, as you know, focused on people with mental illness. Our study focused on people with physical medical illnesses like cancer, diabetes, HIV/AIDS, and other common healthcare challenges of the homeless. Now, many of them also had mental health challenges, and they had substance use or alcohol use histories. What we found out, and this is just the quick results, is that, and we did a random control trial. It's one of about a handful of studies in the country that just show how cost effective our supportive housing is for this population. This is one of the most important slides, is hospitalizations go way down. Also, what goes down is emergency room visits. What goes down is nursing home days. I just came from a presentation by Harlem United, and of course they continue to verify this through what their health home is doing. A subgroup of the CHIP study was people living with HIV/AIDS. The CHIP study was for people with cancer, diabetes, hypertension, HIV/AIDS. A subgroup was HIV positive, and we also showed through a random control trial that the viral load at the supportive housing had significant impact in lowering viral load, which of course is so important for those of you who may be familiar with these challenges. Another very important slide. The CHIP studies were published in JAMA, the Journal of the American Medical Association, and then there was a further study by the University of Chicago on cost benefits. And the findings, which are published in the Journal of Health Research, Health Services Research, shows that for every 100 of these type of individuals that we house, we save $1 million in public funds. That's after you've paid for the rent subsidy and after you've paid for the case management dollars. So this kind of data, again, Carlos is an excellent example of what happens here for those high users of Medicaid. So I just want to end this section by saying the new world of the Affordable Care Act and healthcare in the US needs supportive housing. I've been in this work for 20 years. I have never felt as needed as hospitals are now calling us. The United Healthcare's, Aetna's are calling us and says, how do we get somebody into your program? We say to them, well, after we talk to them a bit, what's in it for us? We're going to save you money. We need resources in order to increase more housing and to fund what we have. One of my favorite slides from a doctor saying they're going to have to start prescribing supportive housing from now on. So let me tell you, focus a little bit more here about our Chicago PSH model for health homes. Basically, it's a pilot project. We've been at it now for a little bit over a year, and it's for high users of Medicaid. We use scattered site supportive housing units, intensive case management, 15 to 1, and we have housed 52 people so far. A little bit about them. All but 12 had either serious mental illness or substance use or both. All of them had the other chronic illnesses that are part of our programs like cancer, diabetes, HIV/AIDS. In fact, this next slide shows you the six highest. The highest there, of course, are cardiovascular disease, HIV, and respiratory disease. These, as we identified high users of Medicaid and got them housed, we identified about 300 potential ones. We were able to house 52 of them. This and the next slide are probably the most important. Look how highly vulnerable these individuals are. All of them had to have at least 2 chronic illnesses because that's the health home model. But almost 3/4 of them had 4 chronic illnesses. Almost half had more than 4. This is Medicaid data. We took the Medicaid data on the 52 and showed where their expenses were. 56% is hospitalizations. This is where the cost savings is going to occur. So we know already that supportive housing reduces hospitalizations for this population, and this is going to be our biggest tool in trying to get resources to make sure that we get funds for Medicaid. Unlike New York State, which already has been using in the past Medicaid dollars to pay for services, most of the rest of the country hasn't. All our supportive housing units, and we fund over 1,000 of them through the AIDS Foundation and our Center for Housing and Health. We've been depending mostly on HUD homeless dollars and on support service dollars from the state. So the fact that Medicaid dollars may be available to us is going to be a major, major opportunity for us. Key elements to our program is it's housing first, harm reduction. We have very low barriers to getting into the housing. Mobile outreach teams have helped us find these individuals. And then we're hoping to add a lot of healthcare services when care coordination begins, hopefully this fall. The housing stability, again, we have a very good record of keeping these highly vulnerable individuals housed. Of the 52 we housed, 47 remain housed. The reason why 5 are not, because 3 passed away in the dignity of their own homes, and 2 disappeared, which happens with this population. So finally, we have put together a health home under the Illinois model that got incorporated on November 2012. It has a board of governors. It's member contributions. In order to join, you have to cough up $25,000, but look who is members of it. And again, there's a handout in your packet. Of the 34 members, which includes hospitals, primary care providers, behavioral health providers, 12 of them are supportive housing providers, and these 12 are not federally qualified health centers. If you add those, there's 15 supportive housing providers. The 12 are like social service agencies, housing agencies that are not medical facilities. Yet we felt strongly enough that this is such a wonderful opportunity to try to make sure that Medicaid dollars helped us to not only fund our present programs, but to increase the number of units by services. And I'll give you one final example here. The East Foundation of Chicago housed over 1,000 units of permanent supportive housing. If Medicaid were to take care of the salaries for the case managers, these 60 or so case managers that cover these units, we could immediately increase the number of permanent supportive housing units by almost half, 500. But we would need Medicaid to help us pay for it. And we're planning to do that by asking Medicaid through our health home that we've set up, and then other, like working with United Healthcare, the Aetnas, to say, help us pay for these units. They will reduce specialty hospitalizations, and it will benefit you because you're gonna save the money you need to save, but it will also benefit us. There's different ways to do this, and we can talk about it later. Care coordination fees, and I know that New York has a bit of a different structure, but also have a dividend in the savings. There's gonna be hopefully a dividend in the savings, and then there's also going to be, of course, hopefully per capita payments after a couple of years that we are saying to this organization, Together for Health, we're part of it, we're gonna save money, we need you to help pay for this. Finally, we see ourselves as being able to braid the HUD dollars, the SAMHSA dollars, the Medicaid dollars through health homes to really not only keep funding what we do, but to increase the number of units, especially for these high users. And whether you're marrying health homes and supportive housing or just engaging each other or just hooking up, I think that's got to be the way to go. And I know, again, New York has a way that you're all mandated to work together. In many other parts of the country, it's kind of voluntary, but we think you guys are doing the right thing. And like you heard earlier this morning, the challenges are enormous. Thank you.